We're super excited to be here today with Jim Loomis, who is both a MD as well as an MBA. Now, Jim received his medical degree from the University of Arkansas, and then he completed an internship and residency in internal medicine at the Barnes Hospital in St. Louis, Missouri. He also earned an MBA from the Olin School of Business at Washington University. He's board certified in internal medicine. He's also completed a certification program in plant-based nutrition from Cornell University. What makes Dr. Loomis even more unique is that he served as the team internist for both the St. Louis Rams football team as well as the St. Louis Cardinals baseball team. Before he moved over to the Barnard Medical Center in Washington, D.C., he practiced internal medicine at St. Luke's Hospital in St. Louis, where he was also the director of prevention and wellness. While Dr. Loomis does not practice medicine or outside of practicing medicine, he enjoys reading history books, cooking, teaching plant-based cooking classes, running, biking, and swimming, and he has completed numerous half marathons, and triathlons as a plant-based athlete. And he's also training for the Lake Placid Triathlon coming up in July of this year, which he can tell us a little bit more about as well. Yeah. So thank you so much for being here today with us.
Thank you for having me. It's always a pleasure.
Fantastic. So let's get right into it. You know, one area of confusion in the world of nutrition is the word fructose. You've heard it. I've heard it. Lots of people are really confused about it, right? Some people believe that the more fructose you eat, the higher your risk for the development of type 2 diabetes. Right. And some people say, no, that's actually not true. It depends on where the fructose comes from. So Can you help our audience understand a little bit about fructose and, you know, is it dangerous? Is it not dangerous? Does it contribute to type 2 diabetes? Does it contribute to other diseases? Give us some insight here.
Yeah, so it's very interesting. You know, I've actually had patients come in who have, diabetes, type 1, type 2 diabetes, who were informed by a dietitian or their diabetes doctor not to eat tomatoes because there's too much sugar, too much fructose in the tomatoes. And I think, there's really a fairly significant misperception, misunderstanding about fructose, what fructose is, how it affects our bodies. Fructose is a monosaccharide. It's the predominant sugar that we find in fruit. It also makes up half of the sugar that's in table sugar. Sucrose is 50% glucose, 50% fructose. And it's also the primary ingredient in high fructose corn syrup, which ranges from about 55 to 65% fructose. And it's very interesting because if you look at kind of the overall epidemiologic data around the risks for things like obesity, heart disease, cancer, diabetes, et cetera, the lack of adequate fruit and vegetable intake is one of the leading risks. And in fact, the WHO considers inadequate fruit and vegetable intake is the fourth leading cause of chronic disease and worldwide. Yet we still have this misperception that the fructose or the sugar that's in fruit somehow is bad for us. And and it's interesting. And I think the issue here is twofold. So one is the dose of fructose that we get from fruit versus the dose of fructose we get from, say, high fructose sugar sweetened beverages, and really this where high fructose corn syrup has become ubiquitous in our society, and also how that fructose is packaged. And so, it's interesting. Traditionally, it's estimated we got about 15 grams, 20 grams of fructose a day through fruit, somewhere in there, maybe 30, 40, depending on how much you ate. There's about 10 grams of fructose in a standard serving of fruit, typically. But interesting enough, it makes up about 1% of the weight by weight of the fruit. You look at sugar sweetened beverage with 65% fructose, that can make up 50% of the weight of the sugar sweetened beverages. And the average intake today of fructose is about 50 to 60 grams. In adolescents, it's almost 80 grams. So we take in a tremendous amount of fructose in the standard American diet today, and it's really skyrocketed since the late 70s, early 80s. And if you look at total sugar intake, added sugar intake today, it's about over 100 pounds per capita, which includes, a significant amount of that is fructose. If you think about what that really means, that means that you have a family of 4, and every January 1st, you bring a 100-pound sack of sugar into the kitchen, and every week you scoop out 2 pounds for everyone to consume. And about half of that sugar ends up being fructose, or a little bit more. That people say, well, that's insane. I don't do that with my family, but in fact we do, because we have hidden this high fructose corn syrup in everything, right? It's in drinks, it's in bread, it's in tomato sauce, it's in candies. I mean, it's really become everywhere, and it's really everywhere. And the way our bodies, when we absorb fructose, almost all that fructose is taken up almost immediately by the liver, where it's metabolized. And there's a lot of, when we overconsume fructose, especially fructose outside of its natural source, it can cause a wide variety of problems, all of which can contribute actually to the development of type 2 diabetes, heart disease, and many other chronic diseases.
Okay, this is super helpful. Now, can you talk a little bit about the actual difference between refined and non-refined fructose? Because, like you said, you can get fructose from a fruit, right? But even despite that, I mean, people look at fruits and they vilify fruits and they say, "Oh, that's a problem," because it contains fructose. But what you're saying is that, in fact, no, that's not the case. So, what would you say to somebody who came up to you and said, "Oh, Dr. Loomis, you don't know what you're talking about. Fruits contain fructose. Fructose can increase my risk for diabetes. I don't believe you."
Yeah, well, so then I would direct them to the medical literature, which suggests exactly the opposite. And it's felt, we don't really understand completely how packaging fructose in fruit specifically lowers your risk for diabetes. But again, part of it has to do with the dose. We're talking doses in the 10 to 20 gram range, 30 gram range, as opposed to the 50, 60, 70 gram range. But also remember, fruit, has a lot of, when you take an apple, for example, which may have, 10 grams again of fructose in it, what else does it have in it? It has fiber. It has cancer-fighting phytonutrients. It has antioxidants, phytochemicals. The soluble fiber in the apple serves as a prebiotic for healthy gut bacteria downstream, all of which can help lower your risk for diabetes. It's interesting. Fruit intake is actually associated with a lower total caloric intake, because when we eat a lot of fruit and fiber, we get full. When we take fructose out of the fruit and consume it independently, it actually may in fact increase our total caloric intake. It's been shown to kind of demodulate the natural effect that food has on both leptin and ghrelin, which are both have to do with appetite suppression and appetite stimulus. There's no fiber in a sugared beverage, for example, which helps make us feel full, so that we don't overconsume calories. But I think the most important thing, though, is really this idea that when it's really, honestly, it's another example of nutritional reductionism, where we stop talking about food and we worry about what food's made out of. And that leads to a whole host of problems besides fructose. It makes us worry about protein and, fiber and all these things, which when we separate, we know now that when we separate the components of food from the food itself, it can it's not the same. And protein is a good example of that as well.
Yeah, that's such an important point, and something that we like to talk about a lot here, about looking at the whole picture, not being too reductionist. So let's talk about low carbohydrate diets and ketogenic diets. So one of the common things that people living with diabetes have, whether it's type 1 or type 2, is that it's characterized by high blood glucose readings. Right. So there is some logic behind, let's just take out the carbohydrate and maybe that'll fix the problem. So can you talk about that a little bit?
Sure. It's various. And that's, obviously keto, to me, keto, this whole kind of low carb paleo movement, starting really with the Atkins diet in the 70s and 80s. I mean, this is just kind of another iteration of that in many ways. But what's interesting about the ketogenic diet in particular is, if you understand from kind of an evolutionary biologic standpoint what ketosis represents, it's the end game. The original ketotic diet, it was famine, right? And our brains can't store energy. We have to rely on blood glucose to supply energy for our brains. And as we start to starve, and we run out of glucose, we've consumed all of the stored glycogen, which is how we store glucose in our muscle and liver cells. When we run out of that, our brains evolved a mechanism, is kind of the end game before we die, to take the byproducts of when we start to catabolize our own protein, our own cells. We create what are called ketone bodies, and it turns out the brain can use these ketone bodies for energy. But really, it's the last stand. It's the last kind of energy source we have, hoping that we stay around that extra few hours or days to find our next meal. And that ketosis was precipitated by starvation, right? Because it was when we started again to catabolize our own bodies. So the idea that somehow by dietary manipulation, by low carbohydrate intake and the corollary of that, if you're not eating a lot of carbs, what are you eating a lot of? Well, protein and fat. To artificially induce a ketotic state, it's crazy to me, right? It doesn't make any sense. Now, will you lose weight in the short term? Of course you will. Right? Will it make your sugars better in the short term? Sure, it will. But if you went on a methamphetamine binge for a week or two, guess what else? Guess what would happen? You would lose weight, and your sugars would get better. It doesn't mean it's healthy in the long term. And there's there's been several studies here recently in the literature which suggest that if you look at people on low carbohydrate diets over the long run, they have a higher mortality rate, increased risk of cardiovascular disease. There's a lot of research around the overconsumption of fat and protein both and increased risk for certain cancers down the road and such as that. Now I do want to make a clear distinction between intermittent fasting and ketosis, like a ketogenic diet. And again, we evolved. You could imagine, again, when I try to understand these things, I think about it through the lens of evolutionary biology. And you can imagine that if we're starting this starvation process, and we're starting to be calorie deprived, if somehow we could involve a mechanism for that to trigger a bump in our metabolism, our bump in our immune system, the ability to heal wounds and fight infections again till we get to that next meal, that makes perfect sense to me. And now some people with intermittent fasting, which is another form of calorie deprivation, but it's not dietary manipulation that's getting you to that state. It's calorie deprivation. Some people will get mildly ketotic toward the end of that, but and if you look at Victor Longa's work, I think that in fact there probably are some long-term health benefits, and even in maybe even particularly as far as type 2 diabetics, improving insulin sensitivity and such as that with intermittent fasting strategies, which is a different thing than a ketogenic diet.
So effectively what you're saying here is that the ketosis, the state of ketosis that's induced via calorie restriction / intermittent fasting / starvation is different than the ketosis that is induced by dietary manipulation and the overconsumption of.
Well, the ketosis is the same, but the ketosis is the same because that's a physiologic state. But the way the dietary manipulation that gets you to that place is completely different. And and to do that through the overconsumption of fat and protein, which is typically what happens, has, I think, fairly significant long-term, profound adverse health effects.
Exactly. Okay. So out of personal curiosity here, there is one author who shall remain nameless just to protect his identity here, who has written a book. He has type 1 diabetes himself. He's in his 80s. He's written a book about the use of a very extremely low carbohydrate ketogenic diet.
Right.
And he regularly publishes his biomarkers, his lipid panel, his A1C.
Yeah.
And as a result of that, he's started a whole revolution of people living with type 1 diabetes in particular that follow his advice, and they say, "Oh, look, I'm getting very similar results to him. My A1C is flatline; it's at like a 4.3, a 4.7. My lipid panel is nice and low. My blood pressure has come down. I've lost some weight. I feel like $1 million."
Yeah.
How is it that somebody who follows a low carbohydrate / ketogenic diet can stave off the effects of, or can stave off the increased risk for the development of type 2 diabetes, heart disease, coronary artery disease, fatty liver, et cetera, over the course of time? Is this a conclusion, or does it happen to, is it individualized?
Well, I mean, I think so unfortunately there are really no great long-term studies looking at, and I'm talking about long-term, because many of these diseases, it takes years. I mean, it takes years to develop colon cancer, prostate cancer, coronary artery disease, et cetera. We know that people who have a lot of saturated fat in their diet are increased risk for different kinds of cancers. The studies that haven't been done are taking two groups of people and putting half of them on a ketogenic diet and half of them on a low fat, whole food plant-based diet, and looking at their overall risk over time. And that research just hasn't been done. And certainly, some people are probably more genetically resilient to some of these diseases than others. That's the case. But what we're talking about here is population. If you look at a whole population of people, we know what the epidemiology says, and it says that if you overconsume, if you don't eat enough fruits and vegetables, you're at increased risk for cancer. If you don't eat enough fruits and vegetables, you're at increased risk for heart disease and diabetes. And if you do eat a lot of fruits and vegetables, your risk is lower for all of those chronic problems. Okay,
so let's talk about protein now. This is one of the most confusing subjects in all of nutrition, and we're excited to talk to you about it, being that you have worked with so many professional athletes. You have some rings on your fingers, and you're an athlete yourself. So let's just talk about the whole topic. But in general, can we get enough amino acids from plant-based?
Oh, sure. Yeah. So I think this is one of the most overwrought, if you will, non-controversies in nutrition, right? And when patients come at me with this, or friends or family say, "Well, where do you get your protein?" And my standard response is, "Well, let me ask you a question. The last time you turned on National Geographic and you saw a special on mountain gorillas or elephants, is the first thing that popped in your head was, oh my God, where do they get their protein?" Right? Well, of course not. And what do they eat? Well, they eat plants. Some of the strongest animals in the world, biggest, strongest, most muscular animals are plant-based. And so the idea that it's just interesting how everyone gets a PhD in nutrition when they find out that you follow a plant-based diet. And it's a fallacy. It's a complete fallacy. And if you look at the math, it's pretty straightforward. The macronutrient ratios of a plant-based diet are about 15% plant-based protein, about 75% unprocessed carbs, and about 10% fat on average. And so, there's 4 calories per gram of protein. So say you're you're a fairly active person and you're eating, say, 2,000, 2,400 calories a day, and you weigh 80 kilos, say. The RDA for protein is about 0.8 grams per kilogram. If you're an endurance athlete, you might need a little bit more, maybe 1.2. If you're a strength trained athlete, you might need a little bit more, 1.6 to 2, somewhere in there. But the thing is, if you're just leading a kind of a normal active lifestyle and you're eating a plant-based diet and you're eating 2,400 calories a day, and 15% of those calories is protein, that if you do that math, that's about 0.8 grams per kilogram, right? So I'm training for an Ironman right now, right? So I'm not eating 2,000, 2,400 calories a day. I might eat 4,000 calories a day on a heavy training day. So what's happened to my protein intake? Well, it's doubled. So now I'm at 1.6, right? Which is right where I need to be as an endurance athlete. If Patrick Baboumian is training for a strongman competition, he might be eating 4,000 or 5,000 calories a day, 6,000 calories a day. So what's happened to his protein intake? Well, now it's almost 2 grams per kilogram. So it's not protein that we should be worried about; it's calories. And if you get enough calories, you will get enough protein on a whole food plant-based diet. And this idea that, we got to mix and match proteins at some, that is just, it is impossible to design a whole food plant-based diet where you're eating a wide variety of legumes and whole grains and fruits and vegetables to become A, protein deficient, and B, protein deficient in any single amino acid. It's impossible to do physiologically. It's really, it is that simple. And I bet people don't want to hear it, but it really is that simple.
Absolutely. Absolutely. So give us a little insight here. You're training for a triathlon. You've done this before. You've run half marathons. You've run marathons.
Yeah.
Run us through a typical day of eating for you during training. What does it look like? I'm super curious.
Yeah. So, so right now I'm kind of in the build phase. And so I'm just trying to kind of drop a couple pounds and build some strength, make myself a little more injury proof. And so, a typical breakfast would be some steel cut oats with some walnuts and flaxseed and blueberries. The reason the berries in particular are antioxidants, have a very potent antioxidant capacity, which help me recover from exercise. Because right now I'm swimming or lifting 2 mornings a week, and then biking and running in the afternoons. And on the weekends, I do a little bit longer swim and run and bike. So I'm working out a couple times a day. Lunch is typically a great big, huge salad but it's not a salad like, not a side salad at the restaurant. It's got kale and broccoli, shaved broccoli and carrots and walnuts and chickpeas and beets and roasted squash. I mean, persimmon, whatever I load it up. And then I'll use like a flavored balsamic vinegar for the dressing. I snack on fruit mainly. I usually have an apple or an orange mid-morning, mid-afternoon, maybe a handful of walnuts or almonds in midday. After my really hard workout in the evening, I usually do a big, huge bowl of berries, again, to help me recover. And dinner is usually legume based. I make a dal or a bean soup at this time of year, things like that. But again, with a wide variety of, I use a lot of pumpkin and squash and colored vegetables. Again, I find that really focusing on eating the rainbow really helps me recover much more quickly. And it's interesting when you talk to athletes who have transitioned to a plant-based diet, the one thing they all say, which I totally agree with, it's the ability to recover from strenuous exercise is the number one thing they've noticed most quickly, because oxidative stress is a normal part of the physiology of burning oxygen for fuel. And in low doses, oxidative stress is important because say you go out for a run and we start to burn more oxygen. That increased oxidative stress sends a signal to our muscles, hey, I'm getting ready to damage you. So get ready to repair me when I'm done. And that's very important. But we can, especially with endurance exercise, you can very easily outstrip our body's kind of innate ability to mitigate oxidative stress. And the only way you can augment our natural ability, antioxidant capacity, is through food and dietary antioxidants. And the only place antioxidants occur are in plants. And typically the more color a plant has, the higher the antioxidant capacity. And I know, for example, when I was in med school, I was a fairly competitive road runner, and I ran my first marathon. And, it took me probably 3 or 4 weeks to fully recover from that, the muscle soreness and stiffness. The second marathon I ran 35 years later, I was 54, and I was running 2 days later. And it was the plants that allowed me to do that. It's, again, the beauty of all of this really is that it turns out that the diet that is optimum for human health and the prevention of diabetes and heart disease and cancer also happens to be the same diet that's best for planetary health and climate change, mitigating climate change, such as that. It's the best diet ethically but it's also the best diet for performance. And I think that this whole performance piece is really starting to bubble up. I think that the documentary, soon to be released documentary, Game Changers, which is specifically about this whole mythology around men and meat and athletes in particular, is going to really open people's eyes about the huge impact that plant-based nutrition has on performance.
Yes. Can you go into a little bit more detail about that movie? Tell us your involvement and just more information.
Yeah. So it's looking to be the final cut is done. I had the pleasure, they screened it at the American College of Lifestyle Medicine meeting just recently and at the Plant-Based Nutrition Conference. So I'm actually in the movie, and I met James Wilks actually through my contacts at Forks Over Knives when we first met, Robbie, way back when. And I flew back to I'd moved to DC by the time when they brought Louis Sohoyos, who's the Academy Award winning director. I'd already moved to DC. And so we went back I called my friends at the Cardinals and they let us borrow Busch Stadium for a day and went out and filmed my interview part, which was really exciting. And it's just so amazing. I had the pleasure of going to the world premiere at the Sundance Film Festival and finally get to meet many of these amazing athletes like Dotsie Bausch and Patrick Baboumian and Bryant Jennings, the boxer, and Kendrick Fears, the Olympic weightlifter, and Liliana Munter, the NASCAR driver, and Damon Mander from the International Anti-Poaching Foundation. So really getting to meet a lot, and Scott Jurek. I mean, some of these guys are like my heroes, and really, it's been such an honor to be involved in that project, and really get to know and interact with some of these absolutely amazing plant-based athletes.
Yeah, I got to tell you guys, if you're listening to this interview, you've got to find a way to see this movie. It's funny. It's very informative. All the studies that are being cited are always in the lower part of the screen.
Yeah.
The cinematography is just gorgeous. I mean, the scene of you at Busch Stadium is it's absolutely gorgeous. So
yeah. And I have to say that I really have to credit James and Joseph Pace, one of the other producers, about the diligence they took to be sure that the film is evidence-based. And there's a lot of B-roll that's not in the movie as part of our interview, but I sent James a stack of research papers that validated everything that I said in the interview. And there was a couple things that weren't there's some statements that were made that may not have been backed up, and we actually took those out. So they've done an amazing job to really be sure that the information that's provided in the movie is truly evidence-based, which is so important because this is a controversial subject, as you know, and the evidence speaks for itself.
Yeah, I mean, you guys are busting some long-standing myths, so the evidence is there.
Right.
All right. So another thing we'd love to hear you talk about is the Barnard Medical Clinic. You guys are doing a whole different style of medicine there. So tell us what it's like for the doctors practicing medicine. I know you're doing telemedicine. We'd love to hear all about it.
Yeah. So it's interesting. I thought I was a smart guy. I graduated with honors from med school, trained at Washington University in St. Louis at Barnes Hospital. It was in practice for 25 years in St. Louis. And I was interested in nutrition. And I would read the U.S. dietary guidelines and look at the food pyramid, and that's what I tried to follow personally and what I talked to my patients about. So for me, for many years, eating healthy meant low-fat dairy, lean meat, fruits and vegetables. I could have some ice cream, just not too much, right? And in retrospect, the disconnect came for me when the nurses are bringing cookies in the office on Monday, and there'd be donuts in the doctor's on Tuesday, and then I go out for a cheeseburger on Wednesday, and there'd be cake and ice cream on someone's birthday on Thursday. And Friday rolls around, I'm patting myself on the back for not eating many cookies, right? So I'm moderating the trees and losing sight of the forest. And I could kind of out-exercise that, and then I hurt my knee playing with my dog, and I had to have surgery, and I waited 3 months, and so my leg got weak, and I didn't do the rehab. And lo and behold, I became a patient. And as I transitioned to being a patient, I realized my doctors were treating me just like I treated my patients. Not once did any of them ever talk to me about my diet or my lifestyle in general. So I developed sleep apnea. So I had a sleep specialist who prescribed me a very, CPAP machine. Ladies love the CPAP, let me tell you. I had an irregular heartbeat, atrial fibrillation, and I had a cardiologist who was, I had an antiarrhythmic pill. My cholesterol was through the roof, and I got I needed some cholesterol medicine. And one day I was laying on the couch and saw Forks Over Knives, and it was such a revolution. And I thought, wow, you mean food could really be medicine? Is it really that simple? And I made a commitment overnight to go plant-based and see what happened and then rehab my knee. Within 3 months, I lost 30, 40 pounds. My cholesterol dropped 100 points. My sleep apnea went away. The AFib went away. Allergies went away. And so it was this, and then I was able to start exercising again, lost another 20, 30 pounds. And that's when I started to re-engage in endurance athletics. But besides this personal health transformation that I had, probably more profound than that was the transformation I made professionally. And it was this idea that I thought I had been this great healthcare provider for all those years. And the realization I had never been practicing healthcare, that what I had been practicing was sick care. And what sick care looks like in our society is, we can lead a fairly unhealthy lifestyle and get away with that for a while, but eventually we'll catch up with us. And, it used to be around 40. Now you're seeing these same kind of chronic diseases like type 2 diabetes in people in their 20s and 30s. But what does healthcare look like or sick care look like in the current system? Well, patient comes in, they're 30, 40 years old, their blood pressure's high. What was I taught to do in med school, right? Well, here's some pills, and I might talk about lifestyle, lose some weight, exercise more, cut back on your salt. But implicit in my message was, I know you can't do that, right? And the pills work great. You come back in 6 months, and now your cholesterol's high. So what do we do next? We do the same thing. Then your blood pressure's high. Then you have diabetes. And then we've just delayed your heart attack or stroke or your bypass surgery. And then you've got colon cancer, breast cancer, right? And then you got Alzheimer's, running out of things to do, so you go to nursing home. So we're adding years to our patients' lives in that system, but we're taking away life from their years, right? We're waiting for them. We're waiting for them to get sick. We're allowing them to accumulate disability. We're giving them drugs that are expensive and have side effects. And this fundamental realization that the only way you can practice true healthcare is focus on the root cause. Because what's the root cause of every single one of those chronic diseases? Well, it's the food we put in our mouths. It's how much we move. It's how we cope with stress and recover from stress through sleep, and the environmental toxins we expose ourselves to, primarily tobacco and alcohol, although I think there's increasing concern about pesticides and herbicides and hormones and antibiotic residues and heavy metals in our food. And so when we flip that upside down, we regain the ability to add years to our patient's life, but sustain life in their years, right? And if you look at my own personal example, at age 52, I'm sliding down that curve. And at age 60 almost, I'm back up here, right? So when was the last time, if you extrapolate that back, when was the last time I was this healthy, right? Like 30, 35, and that's how I feel. People say, how old are you? I said, well, I'm 20 with 40 years experience, right? But that's how I feel. And so I tried to incorporate this into my practice in St. Louis, but it was very difficult because, St. Louis is a great place to get sick, but not a great place to practice true healthcare. I had diabetes doctors accusing me of malpractice for taking their patients off insulin, even though their A1C, which had been 6.5 for the past 3 years, and everyone's patting themselves on the back about how great a job we're doing on their diabetes, is now 5.5 on no meds after transition to plant-based diet. So, I was familiar with what Neil was doing here, Neil Barnard was doing here in Washington, D.C., and I'd heard rumors he was opening up a medical practice here that was really going to use plant-based nutrition in a systematic way is kind of the first line of treatment to help prevent, treat, and hopefully reverse chronic disease. And really on a whim, I sent off my application. I heard they were looking for a medical director, and on a whim, I sent off my resume, and about 2 weeks later, without really looking for another job, I had another career and moved here. And so what we do here is it's a traditional primary care practice in some ways. I mean, I do write prescriptions for statins and blood pressure pills and such, but everyone who comes in here gets to understand that there's a different path that they can take, and that it doesn't involve these pills necessarily. It doesn't involve, this long-term disability. and with really a focus on diet. And so every patient that comes in gets access. We have a free 12-week rolling classes about all aspects of plant-based nutrition, everything from overcoming addiction to reading food labels and how to grocery shop and things like that. We also have Food for Life classes, which include a cooking element, which are also free, both to patients and in the community. We do our own medical nutrition therapy here. We have our own dietitians to provide a more guided expertise. We have a community-based health coaches who are plant-based that can help us. We've started to develop a network of specialists around town who are also supportive of a plant-based lifestyle. So it's really been an amazing thing to see the profound effect you can have on patients' lives when they get to experience what I experienced personally, and it's really been an amazing journey. We've been open 3 years coming up in January. So,
and I'd imagine that you're in a very unique position here because you have both personal experience, improving your own health by transitioning to a plant-based diet, but that you also have a lot of experience in teaching your patients how to, or coming up with a protocol to de-prescribe that they're currently on. So
that's right.
There's a lot of doctors that are actually listening to this interview right now. So can you go into a little bit of detail here about some of the methodology that you use when trying to understand how to cut back on medication for diabetes, hypertension, high cholesterol?
Yeah. So the three kind of short-term effects that you're going to see with the plant-based diet from a physiologic kind of pathophysiologic standpoint is pretty profound reductions in blood pressure, blood sugar, and then cholesterol. Cholesterol medication I don't focus so much on in the short term because there's really no, there's no side effect, if you will, of dropping your cholesterol precipitously. I usually put that as the kind of secondary, and usually after 2 or 3 months we reassess that and start to de-prescribe medication. Obviously, if a patient already has a history of a vascular event or is at very, very high risk, keeping them on a low dose statin certainly is reasonable. The two though that require more diligence are blood pressure and blood sugar. So patients that are on a hypoglycemic agent, especially the type 2 diabetics like insulin or sulfonylurea, I will oftentimes, if they're ready to engage, I will cut that back significantly or stop the sulfonylurea or even cut the insulin dose in half. It's much safer for the patients to run a little high for the short term than to start to encounter hypoglycemia. And then what I do is I have the patients engage themselves. So I have them send me blood sugar logs. I usually have them check their sugars a couple times a day and vary it, fasting in the morning and then vary it lunch, dinner, bedtime. Send me those logs once a week or so as we start to fine tune their sugars. And I teach them, what hypoglycemia feels like and such. Kind of the same thing with blood pressure. I've seen significant reductions in blood pressure very quickly. And again, I teach patients, I show that they're required to get a blood pressure cuff. They check it at home. I talk to them about the symptoms of hypotension or relative hypotension. And we're pretty aggressive about cutting there. And we communicate through the patient portal or using telehealth, as Robbie mentioned earlier, where we can have visits over the internet, kind of like this. So we use those strategies to stay in close contact with our patients as we start to de-prescribe the medications.
Cool. I love this. So you do talk to us about telehealth, because I know that's the sort of next wave of medicine is probably going to move in that direction. Can our clients, can our followers work with you right now? Do they have to see you in person before they see you online? Explain that situation.
So telehealth is, I think the utility of, I think it's clear that telehealth is going to be an incredibly important part of healthcare in the future, is especially as more and more physicians start to engage in lifestyle medicine, because a lot of what I do is really consultative, right? I mean, if I'm trying to get you off your diabetes medicine, I don't need for you to come in here every week. And, DC is uniquely in the middle of everywhere, in the middle of nowhere at the same time. You could live 20 miles away and it could be an hour and a half commute just to get to the office. And so telehealth really allows us to do that. The problem is the telehealth laws are still kind of archaic in many ways. There's licensing issues. I have to be licensed where the patient is sitting, not where I'm sitting. So if Robbie's in California, I would have to have a California license to do a telehealth visit with Robbie, even if he had seen me here in DC. Those laws, it's getting easier to get cross-state licensure, but that's still a barrier. The other barrier is there's some controversy about this first visit rule. Currently, our malpractice carrier requires us to have a first visit one-on-one, even though it's considered legal in many states, as long as you're not doing a physical exam to conduct first visits over telehealth. So we're working with our malpractice carrier right now to help them understand a little bit better about exactly what we're doing, because I think that these are barriers that could really, really fundamentally help patients facilitate long-term lifestyle change, which is really how we're going to do. This healthcare system we have today is not sustainable from a cost standpoint. And, as an aside, the food system we have isn't sustainable from an environmental standpoint. And the food we put in our mouth is the biggest driver of both of those problems. But change is hard, right? I mean, we forget eating is a learned behavior. It's by evolutionary design. If you had to think about walking, I have to contract my quad, flex my hip, bend my knee, you would have walked right past the ripe berries and you wouldn't have seen the leopard and you wouldn't have lasted very long. So our brains evolved a mechanism that, so when we habituate a task, very quickly our subconscious brain takes over, whether it be walking, eating, or in the modern world thriving. And that allows our conscious brain to continue to scan the environment for opportunity and threat. And so, the food preferences, things people like to eat, things people don't like to eat, triggers to start eating, triggers to stop eating, the environmental triggers, emotional triggers, all of that are learned behaviors. And you have to unlearn those and relearn new behaviors to really affect long-term change. And that's a very difficult process. And you're not going to do that typically, as you all well know, with your coaching business. You're not going to do that by getting someone to read a book. It takes a lot of time and effort and hands-on and touch, multiple touch points with the patient. And again, I think things like telehealth really help facilitate that. So I think it's an important part of the future. Still some work needs to be done on the administrative kind of legislative side to make this a more ubiquitous part of healthcare, but I'm encouraged.
Well, this is fantastic. I feel like telehealth is something that is definitely going to help transform the healthcare system that we're currently living in. It's just more accessible for people to be able to interact with doctors. Yep. But really the next level is to try and migrate to a healthcare platform in which telehealth is more ubiquitous, but then also have plant-based physicians who are part of that network.
Yes.
Right? Because, as it is today, there's businesses that exist where you can go get telehealth consultations from non-plant-based physicians, which is great. I mean, you can still get access in ways you didn't get before, but having the two of those together, I think, is a game changer for sure.
Right. And combining that with nutrition counseling, health coaching, all on a single platform, and that you can tailor the interactions. It might be one week you meet with the doctor, and next week you meet with the dietitian, and next week you meet with the health coach. And so it's really about a team-based approach, using things like telehealth to expand the reach of the team. I think that's important.
100%. Well, listen, we could talk to you for hours. I feel like we're only on all these, details about things like fructose and protein and ketogenic diet, because there's so much more. I mean, I've heard you speak in person. I've interacted with you 100 times, and you're a walking encyclopedia. And every time I get a little bit more tidbit, I'm like, wow, this guy's really smart. So,
well, thank you. You guys are pretty.
You truly are a walking encyclopedia. I mean, we love to talk to you about all the journal articles you have stored on your computer, and it's just fun to be talking to people coming at this from such an evidence-based perspective.
Yeah, thank you.
Yeah. So thanks for taking the time to be here with us today. We hope our audience got a good insight here into the confusion that does not need to exist for things like fructose for the ketogenic diet, as well as for protein.
It's true. I tell patients this is so incredibly simple, right? It's just not easy, right? And I think that just to leave with a quote, Daniel Patrick Moynihan, a politician, ex-senator from New York, once said, the paraphrase, we can all have our own opinions, but we can't have our own facts, right? And so if you critically look at the facts about diet, which one has the most overall health benefits? Which one is most ethical? Which one is best for the environment? Which one's best for performance? Well, it ends up, the evidence points to the same place, like I said earlier, and that's a whole food plant-based diet. And those are the facts. Now, you can have opinions about that. Well, what about salmon? Well, is eating a piece of salmon every now and then going to kill you? Of course it's not. Is there something in salmon you can't get from plants? No. Are you exposing yourself to mercury and other environmental toxins, especially in farm salmon? Yes. Is it enough to hurt you? Who knows? Is eating salmon good for marine fisheries and salmon ecosystems? Definitely not. So I think that sometimes we get caught up in these kind of side arguments about, oh, what about salmon? What about eggs? Whatever. But if you step back and you look at the overall big picture and the long-term effects, both again, and you start to think about beyond individual personal health, and you start thinking about, again, the environmental consequences, how we treat animals, the ethics of it, on and on. I think that a whole food plant-based diet, I don't think there's any doubt that anybody who's a critical thinker shouldn't come to the same conclusion if you look at the evidence.